So easy.
Okay, I think within another 2 minutes we will start, because we are having some people, they are following us in Facebook, some of them they are in YouTube, and some of them in here in the Zoom.
I think I'm not dressed appropriately for the background, James. I think I should wear my tees.
Why you feel cold? You feel cold, maybe?
No, I should wear a Hawaiian shirt and like a flat hat and have a glass of, you know, a
With this one over
mocktail
the
with a
head, this
straw
one.
and a lime stuck in there. So.
One minute more, we can then start. Good evening, Assalamu alaikum wa rahmatullahi wa barakatuh. Dear colleagues and friends, it's my pleasure to be between this eminent speaker. I will introduce and talk about, little bit introduce them. We are having a guest speaker, Dr. Ronnie George. He is an MBBS, MS Ophthalmology, DO, DNB, Deputy Director in Glaucoma Service, Medical Research Foundation from Chennai, Madras. I don't know the name of the institute. If Dr. Ronnie can give it to us, it will be great.
Shankar Netralaya.
Okay. And we are having dear Dr. Parul. She's Associate Professor, Department of Ophthalmology, Glaucoma and Neuro-Ophthalmology Facility, Government Medical College and Hospital in Chandigarh, India. And we are having a privilege that to have it with us today. She was with us last year in Quick, and we enjoyed her talks and all the times. And I have been also in Chandigarh one time. I was having a great days there, spent with their colleagues there, Dr. Suresh Kumar and Dr. Baba. Welcome, Dr. Baba. We are having, most welcome, Dr. Baba. We are having also my dear friend, Dr. James Bacon, is a clinical assistant professor of ophthalmology in a Cleveland clinic. He is a consultant ophthalmologist, Eye Institute, Cleveland Clinic, Abu Dhabi. Also, he is a Cleveland Clinic College of Medicine of Case Western Reserve University. Also, my dear friend, Dr. Rajesh Sasikumar, he is a senior consultant glaucoma service, also in Cleveland Abu Dhabi Hospital, associated staff physician, Eye Institute at Cleveland Clinic Abu Dhabi. And the last and not the least is my dear friend and brothers, Dr. Hayat Khan, a well-known figure in pediatric ophthalmology. He is the head of pediatric ophthalmology unit in Dubai Hospital, Dubai Health Authority, DHA Dubai Hospital. Welcome all. It's my pleasure to be between these eminent speakers, and I would like to welcome all of you and enjoy this meeting, and we have to share with us your experience. Also, I'd like to thank all participants that they are with us now. And I will remember them that they can question and raise their hand. They can also live, they can talk and give their question if anyone want to participate. Otherwise, they can send their question and we will be ready to answer this question. Thank you for all. And we will start this evening and this webinar. And I will be the first speaker. I hope that you will enjoy this talk. It will be a very fast. My talk, it will be actually what is the ideal drugs we need for management of glaucoma. I will just say the question, one question, keep it in your mind. Do you think that we are having now an ideal drug that we can use to treat or cure glaucoma? Just keep it in your mind. I don't think so. But let's say if we are having something near to the ideal that we can find. Before that, we have to go back and remember a few things about glaucoma. Worldwide, glaucoma is one of the most leading cause of blindness, and it represents about 10% of 10% from all other disease affecting the eye. So, but the problem of glaucoma, even a small number, if we can see it 10%, it's not a small, but in general, in comparison to others, that the glaucoma is irreversible disease. Glaucoma is one of the most frequent causes of irreversible diseases. The global population is aging, and the prevalence of open-angle glaucoma increased dramatically with age. And the global prevalence of glaucoma of population is now 3.5% between the age of 40 and 80 years of age. So that's why the glaucoma is very important to know and to deal with it as early as possible. It is estimated that the number of people with glaucoma worldwide will increase to about 112 million in 2040. That's why I'm saying the glaucoma, the growing burden of glaucoma is increasing. Glaucoma is a challenging case. Is it a clinical challenge or not? Yes. Why it is a challenge? In most Western countries, approximately half of patients with manifest glaucoma are undiagnosed. So if you think that in an advanced places, still we are having about 50% of the population, they are having a glaucoma and they are undiagnosed. That's why we are having a clinical challenges in dealing with glaucoma. Moreover, glaucoma is often diagnosed late, and this is another challenges. So undiagnosed first, and also at the second one is diagnosed late. Patients also adherence or compliance to a treatment is also challenging. Sometimes it's very difficult. That's why we are looking for a treatment. That's why I keep the title of this presentation. Do we need or do we have an ideal drugs? Because if we are having that, that means there will be more adherence and more compliance, and that means improving the management of glaucoma, which is an irreversible disease. Almost about 75% of glaucoma of patients worldwide, they are having an open angle glaucoma, while the other one is, which is about 26 or 25%, it is an angle closure glaucoma. What matters the most in glaucoma management? What is the most important? The most important until now, we know that the most factor or the key points in glaucoma is the intraocular pressures. We know there is a visual field, but it could be a result of intraocular pressure or another mechanism. But lowering IOP significantly is a key in open angle glaucoma management. Treatment in glaucoma management aims to lower IOP to slow the rate of visual field deterioration. So what we are doing actually in glaucoma, we are only, the most important thing for us is to lower the intraocular pressure. And that's mean we are decreasing the complication and the result of increased intraocular pressure, which is made the most important visual field deteriorations. The only approach that has proven its efficiency in preserving visual field is lowering IOP. The early manifest glaucoma trial demonstrated that 25% decrease of IOP from the baseline reduced the risk of progression by 50%. This is very important statement. That means if we reduce the intraocular pressure by 25% from the normal, that if we have 30, then we decrease it to up, for example, 24, about let's say, or 21 by 25%. That means we are reducing the baseline risk of progression by 50%, and this is very important. That means when early we are treating the patient, we need to decrease the intraocular pressure as much as we can, so that we are going to save the visual field of the patient. The data from AGI's trial combined with data from other studies support finding that achieving and maintaining lower levels of IOP may slow progression of glaucomatous optic neuropathy. This is another statement, very important. So the importance also to monitor the intraocular pressure during 24 hours. This is also, it's features or an important things that part of the ideal drugs we need. If we find a drugs that can also control the intraocular pressure in 24 hours without fluctuations, this is another important thing, because IOP fluctuations have been known to impact glaucoma development. It have a glaucoma progression, impact also glaucoma progression, and also maintenance of intraocular pressure IOP over 24-hour period is of considerable importance. How we can reach to the target for IOP patients. So if we are having, we need to reach the target of IOP. Is there setting for the target IOP? Target IOP should be individualized because there is no target IOP for everyone, for all patients similar. So IOP should be individualized for each eye of every single patient. There is no single target IOP level that is appropriate for every patient. This is very important. So you have to do as individualized. Target IOP should be also re-evaluated regularly because sometimes maybe you are not controlling the patient and it can be changed and fluctuating and lead to a significant reduction in the visual field, and we are not aware of that. Reaching target IOP is often challenging, that's true, because a single agent may not provide adequate IOP reduction for all patients. Sometimes you will use one drug and it can reduce the intraocular pressure if it's a monotherapy, but sometimes you need more than one to control or to reach to the target IOP. It is often necessary to try switching to another class or adding a second agent. Adding and switching strategy to reach to a target IOP must be based on individual patient characteristics. The third point is the need for combination therapy. Sometimes we need a combination, not only monotherapy is not enough. And it found that 40 to 75% of glaucoma patients, after 2 years, they will be not satisfied, or we cannot reach to the target IOP by only monotherapy. So fixed combination therapy should be considered when patients fail to achieve their individual intraocular pressure target with monotherapy. So the question again, what is the ideal drug we need for management of glaucoma? We need a drug that can give a high efficacy and safety, that we can use it less frequent, and it can be more compliance for the patient whenever it is only one time, or it can be less. That means we are achieving more better, so the patient will be more adherent to the drugs. Complication, less complication and side effect from these drugs. It can be day and night cover, that means 24-hour IOP control. And if we can have a drug that can cure the disease, that will be our aim and goal. So what is the ideal drug we need from the management? We say efficacy and safety. I will take only this one example here. I'm not going to talk about all drugs, but we are going to talk about, for example, the Cosopt. Cosopt is an old and the new drug at the same time, and it has shown its clinical efficacy and safety in large number of clinical trials. One of them, this is a mean intraocular reduction at peak of 3 months. It is a Cosopt versus Timolol as the beginning, and it showed that there will be is superior to a Timolol itself. Also in efficacy and safety, we are having another, if you compare a Cosopt with latanoprost or travoprost, and it shown that the combination therapy, which is Cosopt, is more superior to another monotherapy, either latanoprost or travoprost. And this is only to show if we can reach or we can have these ideal drugs or not, or semi-ideal if you want to say properly. Also, another one is combination is an efficacy if we have to see a 24-hour regulations between, for example, Cosopt and brimonidine plus Timolol, and also there is more with Cosopt than brimonidine plus Timolol. Another one also is concept here. If you want to have a concept as to add or switch or add therapy, we can find when we are having switch from monotherapy or we are adding to a monotherapy, we can have more effect and more efficacy and in the management of glaucoma and reduce the intraocular pressure. The second point, we say if frequency and compliance, doses and administration, 1 drop of concept in the affected eye 2 times per daily, it is acceptable, and we want to be more or less, if we can have only 1 time, it will be more better. Complication and side effect, this is a good thing because of the new drugs, which is the preservative-free concept. They are now less because there is no preservative material, which are leading to more complications and more side effects, especially the ocular side effect. So now we are having advanced by using the preservative-free concept, and that means we are having less complication and side effect. Also, we talk about what is the ideal for case of day and night covering, shows significantly superior 24-hour IOP control versus latanoprost monotherapy. Is it curable? I think if we know the answer, this is all kind of anti-glaucoma medication, just treating, but not curing the disease. So in summary, glaucoma is a growing burden and clinical challenges. Almost 75% of glaucoma patients worldwide have open-angle glaucoma. Lowering IOP significantly is a key in open-angle glaucoma management. Reaching target IOP can be challenging, and fixed dose combination are often needed to reach its, and as monotherapy is not enough to reach satisfactory IOP in more than 40 to 75% of glaucoma patients after more than 2 years of having glaucoma. Concept was among the first IOP lowering fixed dose combination approved by FDA with clinical efficacy and safety. So at the end, do you think we have an ideal drug for managing the glaucoma? We need this a comment from my dear panelists here. Thank you, and let us see the comment of dear friends with me here. Any comment, Dr. Rajesh, Dr. Ronnie, Barrel, or Dr. James?
If I may, I think a great presentation, Dr. Amri.
Thank you.
I don't think there is that one golden drug that'll work, because glaucoma is so multifactorial, and the fact that glaucoma management has to be tailor-made for the patient. So one drug might work for some patients, the other one might work for another patient, and combination therapy again is a hit and miss for many patients. So I don't think, and it also depends on the point in time at which the patient is seen. Is it early disease? What type of glaucoma it is, whether it's angle closure versus open angle. If there's angle closure, the extent of peripheral anterior all these will affect the outcome or the efficacy of the medication. So I think in a nutshell, no, there is no one drug.
Any other comments from here, dear colleagues? Dr. Baron, Dr. James, or Ronnie? Or let me ask a question if you want. Do you think, what is your, for example, now there is a talk, we need to start by monotherapy, or when we can start with monotherapy, or we can start as a first choice, combination therapy?
Personally, I would almost always start with monotherapy, because
even Dr. Ronnie, if the pressure is increased, I mean, if the patient came to you, he is 30.
Yes, because the response of an individual patient can vary hugely. For example, I have seen drops of 60% with a single drug occasionally. And once, if you achieve that, then you're not exposing the patient to the risks of two drugs. The one situation where I do consider using a combination is when I see acute secondary glaucoma with pressures in the 40s. There, I would very often go with a combination to try and bring the pressure down as soon as possible. But in most other situations, I would consider monotherapy.
Any other opposite to this opinion?
No, I think I agree with the comments so far. I would just say as well, to emphasize what you said, which is rather than always adding therapy, it's important just to switch therapy. So if a patient's on one medication which is not working, don't just add another medication, stop the primary medication and switch to a different medication, because if you add too many bottles of medication, patients won't use them. So I use a maximum of 2 bottles for a patient before I would then consider surgery. So I would never use 3 bottles of medication. I think that's too much.
Okay, so if you are in a monotherapy and you want to shift, it's better to add, or you have to switch.
So if a monotherapy, you could add, say, for example, it's Bimatoprost.
Then you are going to have more than 1 bottle, as you said.
So if a patient has 1 medication with very poor response, less than 20 or 30% to that medication, I would stop the prime medication and then switch to a different bottle of medication.
Any other comments? Dr. Baran, you want to say something? Dr. Hayat? You are unmute, Dr. Baran, you are unmute.
It makes sense to add another drug. Say, for example, if somebody's on a prostaglandin and you want to add timolol to their medication profile, it makes sense because you'll be able to pick up how much the second drug is causing a drop in pressure and if the patient is having any adverse effect profile. And once you're sure that the patient is settled with this new added therapy, then you can switch them to a combination therapy. Would make more sense later rather than straight away starting with the combination therapy.
Thank you very much. Dr. Hayat, you want to say something?
Yeah, I would agree with the comments of my esteemed colleagues. It was good presentation and it's very clear.
Thank you very much. Now we will have our guest speaker, Dr. Ronnie, and his presentation, it will be on OCT and glaucoma. Dr. Ronnie, the mic with you, please.
Thank you. It's a pleasure to be with you all, and thank you for the invitation. I'll today speak to you about how to use OCT in glaucoma. And when you look at any diagnostic test, you're trying to measure something. And unfortunately, because of technology, you always have technological factors which can affect the measurement. You also have patient factors which can impact the measurement. Whenever we do any measurement, we tend to compare it with normals to see how much it deviates from normals. And then you have issues with your normative database, which can affect your test. And you should keep this in mind for any clinical test, and more so for the OCT and other tests that we use in glaucoma. So whenever you look at an OCT, you have to look at it from a stepwise assessment. You have to look at the quality of the scan, and the quality of the scan you can assess using quantitative parameters or qualitative parameters. And you also have to look for the comparison with the normative database and ask yourself whether it is applicable and whether you can actually compare it reliably with the normative database. So when you look at the components of a printout, I will be speaking to you about both the RNFL and the GCC printouts. Before we go there are a few things that we need to keep in mind. One, the color code. So if the color code is green, it basically means that your values are between 5 to 95% of what they found in the normative database. Yellow is between what would be seen between 1 to 5% of the normative database at the lower level. And red would be what you see in less than 1% and is considered outside normal limits. If you see a white background, it means that it is thicker than what would be seen in 95% of the RNFL. For the cup to disc ratio, it's thickest for a neuroretinal rim and smallest for the cup CT ratio. And gray for the RNFL means not applicable. And for the ONH analysis, it is used when the normative database does not actually contain a disk of that size. So these are the two tests, two basically printouts that I will be discussing. And before we go into any further detail, let me just tell you what the components of data that we are actually interested in. The first is, of course, the age, and that has value. The second are these parameters over here. The third is the RNFL map. The fourth is the thickness map. The fifth is the deviation map. Then you have the TISNET map, and you have the RNFL quadrant and clockers. And each scan is compared to a normative database. You also have to look very closely at the quality, and one of the components of the quality is the signal strength that you're seeing there. So before you do anything further on the scan, take a look at the age, take a look at the quality, take a look at the RNFL map, and take a look at the deviation map for artifacts. So if you look at the GCC, the ganglion cell analysis. Again, similar parameters. Look for quality, look at the thickness map. You have a deviation map here too. You have the RNFL sectors, and you have a few parameters displayed there. If you see a printout like this, which is completely white with no color codes there, it basically means that this age group is not covered in the normative database. And for the OCT, less than 18 years is not covered in the normative database. And actually, you cannot use this to get an idea of what it is compared to normal, but you can still use this for follow-up. So when you look at the stepwise assessment, the next thing that we'll move to is quantitative assessment for the quality of the scan. And we know even from the previous versions of this of the OCT that signal strength could really impact the reliability of your readings. And there's this interesting paper which was about almost 10 years old now, which tells you what happens with a signal strength of 5, which is the top left image, to a signal strength of 10, which is the bottom right image. And you can see that the RNFL thickness varies from 97 microns with a signal strength of 5 to 118 microns with a signal strength of 10. And this range is enough for us to misclassify the image anyway. So it's very important that you have a good quality RNFL scan, and anything that is 7 or more on the Zeiss OCT is considered to be a good quality RNFL scan. What about the qualitative parameters? And this is where it becomes that we need to pay attention to the rest of the parameters on the printout. One of the things is centration, and centration matters because suppose you have an eccentric center, the way this image has been taken, it can impact your measurements. And while this is not a Zeiss OCT, this is just a section of a Topcon OCT, you can see how much of a difference just good centration made to the classification of thickness. So this is an image which is not centered. Can you see the measurement circle here? It's decentered downwards, and the measurement circle on the on your right side is decentered upwards. This is what happened when we repeated the test with well-centered scans. And I'm now putting both of these next to each other. And you can appreciate over here, if you look at just the measurement parameters, that the amount of red that you're seeing in the scan on the left versus the right is quite different. The area that is showing up on the RNFL deviation map is also different in the image on the left and the image on the right. And the areas of damage that you're seeing in the clock-hour image on the left side are more than what you're seeing on the right side. So this is just the sort of effect that a poorly centered scan can have on your interpretation. There are other things you need to watch out. On the RNFL deviation map, if you see these little breaks in vessels, this is an indication that there has been a motion artifact or a movement artifact during the scan. And this, again, is an indirect indication that the scan quality is not optimal. You can get segmentation artifacts, and segmentation artifacts are well known in retinal OCTs, but they do happen in glaucoma OCTs too. And so typically when you look at the extracted tomograms that you would see, this red line basically shows you the ILM and cup boundaries. And these little dots are 150 microns above Brooks membrane. This black line over there shows you the RP layer. So what you're seeing over here is an irregular placement of the segmentation line. And you can see it's obvious that there is no tissue below this. So anything that you get in a scan like this is absolutely useless. Here is one more scan where you're seeing an irregular placement of the segmentation line, which is almost gone to the top. So when this scan is coming to the top of your measurement window, again, you're going to get very, very erroneous readings. This is something that you just need to look for on a scan. So let's look at this pair of scans now. So if you look at this pair of scans, first thing, very poor signal strength in the left eye, 3 out of 10. And the same thing holds for the scan on the right. Then you're seeing this big black patch over here. And you're also seeing black patches over here. Black patches indicate an area where there has been no measurement done. So black patches are not something that are seen normally, and they're not physiological. If you see this sort of black on the scan, just discard the scan. In this case, it is because of a blink artifact. So there has been no data collected in this inferior part of on the inferior quadrant. And you're also seeing this is the same slide that I showed you previously, segmentation error causing loss of data. And on the scan on the right, you can see that this that the image is going right up to the top of the measurement window, and that's also impacts the measurements that you're getting. So what about, so this is another image on a GCC, and here you're seeing that there is areas over here which are actually artifacts. And these are impacting the measurements that you're seeing. When you repeat the scan without the artifacts, you're seeing a completely normal image. And this is because whenever you see areas of loss, they get averaged across the whole scan, and you start seeing localized defects related to that. So the next thing that you would go to is comparison with the normative database. And when you look at the normative database, there are three things, there are multiple things that you compare. One of them is the neural rim thickness, the RNFL thickness, the RNFL quadrants, and the RNFL clock hours. So the image on the left is a normal image. So you're seeing that classic double hum pattern in the RNFL thickness, where the superior and the inferior are the thickest, with the other parameters being thinner than that. The image on the right is from a glaucomatous eye. And here you have the continuous line, which is the right eye, and the dashed line, which is the left eye. So you can see just over here, when you follow the dark line, you can see that it's dipping into the yellow and red zone over here. And this is suggestive of localized thinning, while in the right eye, while the left eye with the dotted line is completely in the red, suggesting that the entire RNFL is thin all across the disc. When you look at the OCT scan, the RNFL thickness scan, again, you're seeing a localized loss of the double hem in the left eye. The right eye is more or less okay. In the quadrant scans, the scan of the right eye is normal. The scan of the left eye is showing both superior and inferior loss. But in the clock hour analysis, you're seeing early focal changes in the right eye, which correspond to what you saw in the top image of the neural rim. And you're seeing changes, extensive changes in the left eye. So these are factors that you would need to look at on the printout. And then you would need to look at the average, the summary parameters. So the image, the table on the left basically is completely normal, and you can see the RNFL symmetry is close to 98%. The closer it is to 100%, the more symmetrical it is. And we do know that asymmetry across the eyes is one of the indications of an asymmetric glaucoma. The image in the middle shows you a fairly moderate to severe disease in the right eye, and maybe moderate disease in the left eye. And again, pay attention that the disc area is grayed out. So what this means is for this age group, you actually don't have this disc size in the normative database. Now look at the image on the right, and here you can see that not only the disc area, but the rim area, the cup to disc ratio, and the vertical cup to disc ratio are all grayed out. And this is because this image has a disc area of 2.9, which is beyond what the OCT has in the normative database for any disc, and 1.27, which is less than what the OCT has in the normative database for any age. So then you will not get any of the other disc parameters either. So now let's move back to the same graph, and let's see what this did to our summary parameters. And here you can see that lower average RNFL thickness, which is really, really low, is actually lower than the floor effect, because these black areas have not got any measurements and they're counted as 0. Now you look at the RNFL graph here, and it is reaching the floor. It's reaching absolute 0. And that never happens in a normal eye, because even if the RNFL is not there, you still have some tissue left, supportive tissue of the retina, and you don't get a 0 measurement. So you need to, so when you look at this image in totality, you not only have a poor quality score, you have artifacts there, you have segmentation artifacts, and because of the segmentation, because of these blink artifacts, you have a huge impact on all other parameters. So an OCT like this should be repeated and should not be used for any analysis. We'll come to this example here, which is basically a superior arcuate defect there, and you can see that it corresponds to the inferior arcuate defect as you're seeing over here. And you're also seeing a small inferior arcuate defect on the RNFL deviation map. This is somebody with more advanced disease with a biarcuate defect on the visual field. And you can see a similar sort of biarcuate pattern here. I'm showing you this mostly because I want to show you the macular cube over here. So the macular cube, the red areas indicate abnormality. And a very important sign on the glaucoma, on the ganglion cell analysis, is this sort of line that you see. This is a temporal raphe sign, and is fairly classical for glaucoma, because we know that glaucoma follows a hemifield, and you can see this superior hemifield damage here without any inferior hemifield damage on the visual field. A similar sort of pattern is seen on the macular cube also, and that's something that is very useful to look for on the GCC analysis. So let's just take a look at this scan in totality and see what is happening. So if you look here, the right eye has a classic hourglass appearance, which is what you see in normals. The left eye has a loss of the hourglass appearance. You also have average retinal nerve fiber layer thickness, which is within normal limits in the right and abnormal in the left. You have a focal RNFL defect here, but it really doesn't seem to be very significant. And in the left eye, you have both superior and inferior RNFL defects. You have superior neuroretinal rim thinning, which is little borderline here. And here you have generalized thinning across the entire neuroretinal rim area. Here you have the normal double hump pattern, and here you have the loss of the double hump pattern. Here you have no RNFL thinning in any quadrant, and here you have superior and inferior RNFL thinning. And here you have focal, and here you have generalized thinning. And both images, keep in mind, have very good quality scores of 10 and 8. So this is how you would actually interpret an OCT in totality. Before we finish, I'd just like to point out a couple of things. Whenever you look at the OCT in glaucoma diagnosis, in advanced glaucoma, it has good diagnostic capability. Any test has good diagnostic capability in advanced glaucoma. In moderate glaucoma, it has moderate diagnostic capability. And in early glaucoma, it has relatively poor diagnostic capability compared to the other two. And this is because any structural test is dependent on its normative database. And there's a huge inter-individual variability among most optic disc parameters. And because of this huge inter-individual variability, differentiating very early disease from normal is more difficult than advanced disease from normal. And you should keep in mind that that's why every abnormal test does not necessarily mean abnormality. And if you want to really maximize how to use the OCT in practice, if you see a disc which is absolutely normal, any abnormality that you see on the OCT is likely to be a false positive. On the other hand, if you see a disc which is really fairly damaged, then it's almost like almost every test that you do will be abnormal. So to conclude, you need to understand technology. It has its limitations. You need to correct for artifacts. You need to keep in mind quality. And don't forget the statistical basis of every test. Every abnormal test is not disease. Do not interpret the diagnostic test in isolation. And again, without a careful clinical examination, all these tests have very little value. Thank you once again for the invitation, and I'd be happy to take questions.
Thank you very much, Dr. Ronnie, for this very comprehensive and excellent presentation. Actually, you go to a direct point. That's what we need. So thank you very much. If there is any question from the panelists before we have any question from the participant. Any questions from here, any of the speakers, Dr. James, Rajesh, Paul, or Hayat?
I just want to add also that all these databases are predominantly Caucasian-based databases, and the variations that are there in the Asian population, that also will add to a lot of complexity in evaluating the test. I think Ronnie will agree with me on this one.
Yeah.
So that should be taken into consideration while we interpret the test. Absolutely.
And it's a challenge for most of the companies to give you race-specific databases because it's very expensive to do that. They have to get
Dr. James, you are unmute. If you are talking, Dr. James, you are talking with us. Unmute.
Hello. Thank you very much for that excellent rundown on OCT, which is an important modality we use a lot. When do you think OCT lets you down? When do you ignore OCT in your patients, do you think, Dr. Ronnie?
Yeah, so if I have a patient with a very large disc or a disc which is outside the normative database, I know I really cannot rely on it for diagnosis, but it may still help me with follow-up. If I have a very high myop, greater than -12 diopters, there are no myopes in the OCT database. If I have somebody with an anatomical abnormality, don't forget all the eyes are compared to normal eyes. So if you have anybody with an anatomical abnormality, it's going to be abnormal. But keep in mind that these may still have a role when you follow them up, because then you're comparing them with the baseline images of the same patient. But for diagnosis, they have less value.
Thank you. Also, another quick question. I find with patients with very advanced glaucoma with very, very poor looking OCTs, with, basically a flat line on the OCT side profile. I find very little value in OCTs in these patients with advanced glaucoma. I tend to rely more on a 10-2 visual field or a 24-2. Do you find that as well, or do you still find it useful in very advanced glaucoma?
No, I would agree with you that in very advanced glaucoma, the OCT has little to offer. But there's an interesting paper which modeled progression on visual fields versus OCT. And they found that 70% of the time, you're going to see progression on the OCT in early glaucoma first. But 30% of the time, it will happen in visual fields. But in advanced glaucoma, they found the converse, that most of the time, you will detect progression on the visual fields. And about 30% of the time, you would actually detect progression first on the OCT. But for those of us who work in this part of the world, we know that our definition of advanced and the Western definition of advanced can be quite different. I mean, I take your point when you're saying you're going to follow them up on 10-2s because that's all they have left. And I don't think the OCT has got much of a role in that.
And also there's the floor effect. So that sort of confounds the problem because all technologies, any imaging technology has a floor effect beyond which, you can't measure. So if there's any further loss, you will not really see the difference actually.
Yes.
We have one question here, Dr. Ronnie. If OCT is poor diagnostic tool in early glaucoma cases, so what is the benefit here as far as advanced glaucoma cases can be easily diagnosed?
Yeah, so there is not much benefit in an advanced glaucoma case. In fact, most advanced glaucomas you can diagnose clinically. The use of the OCT there would just be as supportive evidence for you to look for progression. You're anyway going to do a visual field. If you want to do an OCT also to see whether you're seeing change on that, that's okay. But most glaucoma is actually a clinical diagnosis. These are just supportive tools. I would not really make a diagnosis of a glaucoma based on any single diagnostic test alone.
Okay, this is a question for all the panelists here about the normotensive glaucoma. When to treat? What is the IOB when they start to treat on? What is the IOB when they start to treat on? And what is the target pressure? Dr. Baral, I think you are having a lot of information about this one. So if you can just
Well, normotensive glaucoma is anyway a diagnosis of exclusion, and just to put one intraocular pressure reading as a cutoff for basing our treatment is, I don't think, the right way to go. Very thorough systemic examination. Actually, the first thing to do to label your patient as normotensive glaucoma. And after that, if you think that the visual field parameters and the appearance of the disc itself is tilting your diagnosis towards a normotensive glaucoma, then yes, based upon the damage which we see on the fields and the OCT and an appearance of the optic disc, would like to bring the pressure down anyway, but would be very, very critical before labeling somebody as normotensive glaucoma. So I wouldn't really want to put a value of intraocular pressure to guide somebody on treatment. I would just tell them to be very, very, very thorough with every aspect of examination they have to offer to that glaucoma patient, and also to get them systemically evaluated.
You mean there is no target pressure? I mean, it decreased by 30%?
Would be very tailor-made for a patient, for actually every patient, but more so for a normotensive glaucoma patient. For each type of patient, we would want to bring down the pressure at least by 30% of their baseline value. But that would really differ because normotensives anyway have a pressure profile towards the relatively normal label that we put to the value of intraocular pressure. So we just have to follow them up on the amount of damage they have and how much our therapy is benefiting them. So probably they would, in my experience, I would say that I would like to watch them much more closely, would follow them up with a little bit more frequent visual field tests and more frequent OCT in the early couple of years I'm seeing them to see if they are rapidly progressing. And based on that, I'll change the value of my target pressure.
Thank you, Dr. Baral. Any other comments before we move to the next speaker?
I'd just like to remind
Yes.
that if you recall the collaborative normotensive glaucoma study, approximately 30 to 35% of patients actually did not progress over 6 years' time. So sometimes some of the NTGs are one-time vascular insults, which you cannot get on history or even on a clinical examination. And they may actually never progress. So if you have a normal tension glaucoma that you've started on treatment and they're stable for a few years, you could even consider whether,
Withdrawing the
stopping
treatment.
treatment and seeing whether there is anything actually going wrong there. So
You
careful.
don't need to treat him, and you can stop medication and check him.
And you still have other types of normal tension glaucoma pressures at 10 consistently who continue to go downhill, and you cannot find a reason for it.
Absolutely agree with you, yeah.
Thank you for all. Now we will go for Dr. Barrel, and she will give us an approach to glaucoma suspect. Dr. Barrel, the mic with you.
Yes, please. So am I visible? Yeah, the slides are visible.
You didn't share your screen yet.
I did. I did share my screen. I think there's some glitch. Just give me a moment to fix it.
Okay. We are having several questions here. We can just go ahead through it till Dr. Barrel. Okay, Dr. Barrel, you are okay now.
Well, good evening, everybody. The topic given to me for today's evening session was approach to a glaucoma suspect, and I would be sharing some of my thoughts about the topic. Why are we so concerned about the suspect category? Because it entails a lot of fears which the patients have as regards the fear of going blind. And with the physician, they don't want to do any harm, but they are very confused. Should they wait to start the treatment, or should they safely continue the patient on observation? And then again, a patient's perspective that why are they spending their money on a disease which has not even manifested that yet, and for which they have no symptoms. So keeping those fears in mind, let's go and see who all we need to address and who all we can skip carefully by carefully observing them. So POAG suspect or a glaucoma suspect was, as far as 2000 was concerned, it was defined with the pressure value of over 21 millimeters of mercury, with changes in optic nerve head and visual fields. But after the year 2000, the American Academy, they revised their PPP for the POAG suspect and just mentioned that consistently elevated IOP should be there. They did not specify any value. Along with appearance of optic nerve head, which was suggestive of glaucomatous damage, with corroborative visual fields suggestive of the damage. So let's look at some case scenarios wherein we start suspecting a patient of having some sort of a glaucomatous damage. So here we have a patient who was referred to us just because he had large cup disc ratios on a routine examination. The pressures were normal in both the eyes. The CCT was fine in the normal range. Gonioscopically open angles and even the fields were normal. The only concern which the physician had was such a stark large cup disc ratio. Second scenario which baffles us is of a patient who presents with relatively high pressures in late 20s or even somewhere in mid 20s. And usually people have a tendency to start them in just on one reading of an intraocular pressure. So this gentleman was started elsewhere on timolol, and despite medication for a couple of months, he still maintained pressure in the early 20s. The CCT was somewhat thicker with open angles and normal fields. We tried to do a phasing and we found out that there was not too much of a significant pressure difference in both the eyes. The right eye had a phasing difference of about 6, while the left eye was normal. So here, usually the patient, the concern that a physician would have is of a high intraocular pressure and would be very concerned as regards when a glaucomatous damage would appear for such a patient. The third scenario is here I have a representative patient, a 46-year-old female with good vision, good pressure profile, thick corneas, open angles, and a cup disc ratio of 0.6 and 0.8 respectively in 2 eyes. and the disc is suspicious. The OCT is having subabnormality, but the fields are normal. So is it pre-parametric glaucoma? And should you start treating every patient of pre-parametric glaucoma? Another scenario of a field suspect. So just the first couple of fields and you start treating, that's something which needs to be avoided. Here, we just have to see that there should be no correlation. There is no correlation between the disc and the field. So such a field is liable to cause a suspicion. A good dilated examination, excuse me, a good dilated examination to see the periphery and even to see the entire fundus beyond the optic disc is something which many a time most glaucoma people or the general ophthalmologist sitting in the OPD, they just tend to forget, because a patient may have additional fundal pathologies along with a suspicious looking disc. A lot of artifacts like dermatochalasis or ptosis are often ignored, and we often tend to forget that even the wisest of patients can have a learning curve in adjusting to the visual fields. So how do we put the pieces together to address the situation? Key elements of the history have to be very, very thorough. You take a very thorough ocular systemic drug history. Family history, of course, is utmost important, as there is 4 to 9 times extra risk of developing a POAG, more so in the siblings of the patients. Review the patient's medical records, give a thorough attention to hypotension, history of any sort of migraine or vasospasm activity. And often we tend to ignore subtle complaints like impaired contrast or a poor dark adaptation, which may be signs of early glaucomatous damage. So it's a good idea to remember the predictive and the risk factors and put all those factors in your profile when you are developing a file for this patient. IOP, CCT, and disc hemorrhages have shown to be the predictive factors which have been found to have a positive impact on the development of open angle glaucoma. A thorough examination after a good history, cover all the aspects, take good pressures, repeat multiple pressures at multiple time points of the day, because just a single reading is like taking a screenshot of the pressure profile. CCT, gonoscopy, draw your optic disc on the first visit, draw it again on the second visit, so that each time when you look at the file of the patient, you have something to go back to, in addition to clicking a good fundus photograph and seeing a red-free optic disc profile as well. A good visual field examination repeated a couple of times to have a baseline, and OCT, as Dr. Ronnie had already talked about. So let's apply these concepts to the cases which we had seen. So we go back to our first case, which had large cup to disc ratio. Everything looks fine. This is an old patient of mine. Everything looks fine on the OCT. The disc size was measured, which was relatively large. The patient was followed up for and at 18 months, we repeated the disc photograph, which looks almost essentially the same. The pressures are within the normal limit. The disc has not progressed. The OCT has not changed, and no changes in the visual fields as well. So very safe to say that in such a large disc, a large cup is almost physiological, and the symmetry of the cupping and the symmetry of the disc size points towards a physiological cupping, and it's safe to observe such a patient. So here I want to highlight that the size of the optic disc, it matters. The conventional cup to disc ratio concept, whether we need to continue to use it or not, is something that we all need to remind ourselves that it's time to change this practice. Because if we look at the image here, the first 3 images are having 0.4 cup, if we just talk in terms of the cup to disc ratio. But it's the position of the cup that is making all the big difference. So the image 1 and image 3 are actually having glaucoma, while the image 4, which looks to have a very significant cupping, is actually of a normal patient with just a large disc. So here comes the concept of disc damage likelihood scale, which considers the size of the disc, and based upon that, it gives a stage to the optic disc. what it really banks upon is not the cup, it banks upon the neuroretinal rim. And for each quadrant, neuroretinal rim width is measured, and based on how much rim width is missing, or whichever part is the narrowest, you see on the scale which is there in this, just corresponding to the disk size. So here I have a representative image at the bottom, which is having a rim width which is narrowest from about 0 to 50 degrees. And it's a relatively large disk, so it falls as a disk category of DDLS6. Now, this concept of DDLS is very essential because it helps you to even counsel your patient. To everybody, green is normal, yellow is borderline, and red is something which is alarming. So if you show to your patient that, see, at this time point, you are having a score of 1, 2, or 3, and you would want to maintain this score by a regular follow-up, or maybe eventually a treatment that would be needed. So if you explain it to them based on this graph and you follow up a patient, it's very easy for them also to understand what's going on with them. The moment they skip a follow-up and they come to you later at some point and they have gone from green to yellow, you can tell them to be more consistent with their follow-up, or maybe you can start treatment for them. You can also see how steep is the slope which has changed over the years. So if somebody has progressed from DDLS2 to DDLS6 in just a couple of years, you know the slope is steep, and you would really be aggressive in your treatment. So that's a concept which can be applied in our clinics when we are following up patients with the suspicious discs, and even patients once they have established glaucomas. The appearances of the optic discs can be deceptive, and a lot of times there can be an overlap between glaucomatous as well as non-glaucomatous discs. So we can have tilted discs with glaucomatous damage, or we can have large myopic discs with a very large 360-degree peripapillary atrophy, or with some discs with other anomalies. So all that has to be kept in mind, and especially for this category of deceptive discs, imaging modalities should not be really considered for basing your decision as regards treatment. A special mention when we talk of optic disc morphology is a disc hemorrhage. We need to remember that in the ocular hypertension study, the incidence of the open angle glaucoma developing in eyes with a disc hemorrhage was about 13.6% compared with the eyes without a disc hemorrhage, which was approximately 5.2% over 8 years. And EMGT also showed that 13% of patients had disc hemorrhages at baseline, and the presence of disc hemorrhage is associated with progression. So applying the concepts that we learned to the case scenario number 2, where the pressures were elevated, but there was no glaucomatous damage yet. So this patient would be safely labeled as an ocular hypertensive, normal optic disc and structure, as ascertained by reliable fields. But we need to stop them in the early part of the continuum, and we don't want them to develop a frank damage. So here, a lot of people try to use the concept of risk calculators. Amongst the calculators that are available, the one which has been given by the Washington University can be really used in practice because it applies the concepts of ocular hypertension study and EGPS both. And at times when you are in real doubt and you know that you don't want to keep your patient hung up, then if the risk is more than 15% on a calculator, you can suggest them treatment. But it's very important to talk to all your ocular hypertensives and tell them the risk and benefit ratio of starting or not starting the treatment. Another calculator which gives you the threshold IOP to treat such a patient is from the Wilmer group. And they tell you at what time, at what intraocular pressure level it would be wise to start a treatment. But it has a big caveat that the static measurements of IOP, even if they are repeated, they do not capture the short-term fluctuations. So for me, I don't use calculators in my clinical practice. I just keep them on a close follow-up. So for me, the factors that favor treatment are somebody who has a highly elevated pressure. So if the pressures are more than 30, just to avoid the risk of any sort of a vascular occlusion, I would start them on treatment. If there is a combination of these factors wherein the CCT is thin, or if the cup disc ratio is really high, and there is a disc hemorrhage or a positive family history, my decision to start treatment would be tilted in favor of treatment. In patients who are really elderly with thick CCTs and who understand what the disease entails and are willing for a follow-up, I would like to keep them on a follow-up and observe them. The third scenario of a pre-parametric glaucoma, we know that pre-parametric glaucoma refers to presence of signs of characteristic optic neuropathy, but damage shown on the RNFL before the development of visual field defects. And almost half of the ocular hypertensives, they tend to convert to a pre-parametric glaucoma. They might not go into developing a full-fledged version of glaucoma, but yeah, the pre-parametric changes are there. And almost 60% of ocular hypertensives, they have RNFL defects in about 6 years before the visual field changes start to happen. So it's a good idea to at least follow them on imaging. Watch out for red or green disease on OCT. That's something which is a very lucrative trap for most of us if we are not very careful and looking at the scans, and Dr. Ronnie has done a great job in showing us how to interpret each part of an OCT scan. So watch out and compare the damage you see on the OCT scan with the fundus image that you have in front of you. Earlier, there were not too many randomized controlled trials with address the issue of PPG, but now there are a couple of studies. The pre-parametric normal tension glaucoma study actually calls it a normoperimetric glaucoma. And it says that in patients with optic disc hemorrhage with poor pressure control, these are the risk factors for prognosis, for a poor prognosis of pre-parametric normotensive glaucoma patients to go on and develop a full-fledged glaucoma. And the latest study, which is the pre-parametric glaucoma prospective study, talks about the reduced basal optic nerve head blood flow, and it suggests that OCT angiography is a good adjunct, and if that's available with the physician, they can go ahead and use it and follow up their patients. So putting all this together, you need to have a sort of a follow-up plan, how frequently to call a patient and how to evaluate them. So based on whether you start treatment or not. So if you have not started the treatment and you know that the patient is not a high risk, you can safely call them initially after every 6 months for a year or so, and then you can call them yearly or maybe even 2 yearly based upon how things are going with them. If the treatment has not been started, but the patient looks like to be in high risk, then initial frequency can be a bit frequent. You can range it and tailor make it for a range of 3 to 21 months. If you have started the treatment for a patient, the target IOP is achieved, the patient is a high-risk patient, it's good to follow them up a little bit more frequently, 3 to 12 monthly. And if the target IOP is not achieved and the patient is still high risk, more frequent follow-up, almost close to 2 or 3 monthly follow-up. So in the nutshell, I would just like to say that the approach to treatment for glaucoma suspects is actually an art and science. It has to be absolutely tailor-made. There is no fixed protocol. You need to educate and counsel your patient. The patient needs to have trust in you, because if you want to keep them on observation, you don't want them to go doctor shopping, and you don't want them some XYZ to just jump on and start treatment for them, because it's very easy to start treatment. It's very difficult to take people off treatment when they don't actually need it. So watchful fating is a reasonable approach for most glaucoma suspects, unless until you have factors that favor their progression into a POAG. So with that, I conclude my talk, and I would just suggest that we document everything very well, because that goes a long way in following up the patient. So thank you very much.
Thank you very much, Dr. Barol, for this comprehensive, actually. And you give an example for each, something that in our mind. But in summary, the things that you want us to focus on. If you can just repeat the pressure itself, the cupping disc ratio, and if you want to do the OCT to see the RNF, and I think the last one I don't remember what is the fourth, if I remember it nicely.
we would be checking pressures, but not just a single value of pressure. No pressures for NCT when we talk of glaucoma. We need to do a good applanation tonometry, repeat them a couple of times at, if possible, different times of the day. Dilated examination for the disc and to look at the retinal nerve fiber layer. So for the baseline and for the subsequent visits, we click a photograph, red-free as well as the color photograph. And I always draw what I see on the disc at that time point along with in the patient's prescription card. So even if somebody comes to me randomly and I flip through my records, I have something to fall back to. So documenting the changes on the optic nerve head is quintessential, I think even much more important when we are just looking at the disc. As regards pre-parametric glaucoma or ocular hypertensives, of course, an imaging is must because we need to consider both structure and function together. So yes, an OCT, a visual field, everything is mandatory. But then once you start to think of whether you want to start a treatment for this patient, I would put everything on table and see what is matching. And if all falls in place, and if the patient is likely to have glaucoma, I would call them frequently. Otherwise, just observe them 6 monthly or so. And if he's stable for a couple of years, then yeah, an yearly follow-up and maybe then a 2 yearly follow-up.
Dr. Baral, there is something
lumpy to start on treatment.
Dr. Baral, there is something it comes to all of our minds that we know glaucoma is a disease. Sometimes it can lead to a destructive without we cannot notice that. I mean, sometimes it's a slow processing that happened and we are not noticing that. How can we, control, or how we can do in between? If we are having a pressure on 25, 26, so I will be afraid if I will not give this patient a drug or treat, I didn't treat him. Maybe later on he will have complication or visual field loss. So sometimes it will not show easily, or you cannot detect it easily if even sometimes not every place they are having all the tools that we can detect the visual field changes.
And if you think that the patient doesn't understand the concept of observation, of a frequent follow-up, and you think that you're likely to lose him despite having explained the entity, then yes, you might start them on treatment. But if 26 is not something, if you have to see the CCT for the patient, if a little towards the higher side, if the OCT is fine, the visual fields are fine, just 26 is not enough to start the patient on treatment. That's my take on it. I would like to call them again, probably repeat the tests. And if all is fine, and it's a slow progressing disease, and we are just talking of primary open angle glaucoma, I'm not addressing any secondary element to it. So they are not going to go downhill rapidly. So I guess it's still safer to observe them if they understand that they just need to come for a follow-up. If you think there are additional factors, which in addition to the pressures, then you might consider treatment. But otherwise, I would like to wait because I don't think it's going to go downhill anywhere soon.
Any question or comments from dear panelists here before we go to the question we are having? Ronnie, Dr. Ronnie, James, Rajesh, Hayat, anyone want to say something or to comment? Okay. We have here a similar question. Do you just depend on OCT or always in combination with visual field?
Always in combination with visual field, and I would pay more value to a visual field than an OCT. I'm not treating a printout, I'm treating a patient. So we have to put everything together. So there can be so many factors which can go wrong in an OCT. If we are just looking at a printout, and we might be missing a lot of artifacts, a lot of other things that Dr. Ronnie has already talked about. So I think you need to take a visual field, match it with the changes that you see on the optic nerve head. That should fairly solve your problem for at least 90% of your patients. OCT is good follow-up and have an idea, but then I would not base my treatment on just an OCT.
Okay, what is your decision if there is a disparity between the OCT and visual field?
My own clinical judgment for that matter.
Okay, so we'll go back to the clinical judgment. Okay. In high myopia with glaucoma, any alternative to OCT to be used in the assessment of glaucoma? I think maybe these kind of questions to all. Dr. Ronnie or Dr. Barrel, also you can give your opinion.
I think I answered that question by typing in the answer there to the questioner.
No need, please, to answer anyone unless we finished and we didn't answer. So maybe some people, they want to hear this. But if you want to answer it also live, it will be a great.
Basically, I think all imaging devices are limited in sort of interpreting myopic discs, and I think that's the bottom line. So everything should be interpreted with caution. There's no one single device that does it any better than the other at this point in time. So
there is a question already, maybe you answered, Dr. Barrel. If there is no damage and IOB is 25, would you still give treatment, or as you said, maybe you will not start on treatment unless you compare with other things, right?
I'm sorry, did you say damage?
If there is no damage,
If there is no damage, yes, I would safely observe.
How for frequent
I think we
QC,
also have to. I think we also have to look at the various risk factors. If there's a family history, like Parul mentioned, the pachymetry, you got to take all those into consideration. Are there any vascular sort of considerations in these patients? Are they, so you have to add those into account, and not just the number of the 25. That's important.
How frequent you see splinter disc hemorrhage in glaucoma patients?
Dr.
We don't see it as commonly as has been reported from the Far East. For example, in Korea, they see it very often. Rajesh has worked in Singapore, so I don't know what his experience has been in Singapore, India, and in the Emirates.
I think across all three populations, I think it's not as prevalent as that's been published. I think the Blue Mountain study, in fact, said that it's about 13.5 or 14% in those who had POAG, and the prevalence has been but the average prevalence, I would think, has been anywhere from 4.5% to almost 50% in some populations. Now, you have to understand that these are all based. So if you do a clinic, which is a glaucoma clinic, where the prevalence of glaucoma is 100%, you might find 50% of patients have NFL hemorrhages, because you're finding people across all spectrum of disease coming in. But if you take a general population, it's about 0.5 to 1.5% maybe. So we don't know the answer to this clearly, but it's not as prevalent as has been published. At least I have not seen it anecdotally, like Ronnie said.
We are having one of colleagues who want to ask a question. Mr. John, can you open for Dr. Carter, please? Yeah, Dr. Carter. Can you unmute him, please?
We're awaiting for him.
Yeah, he is open. Okay, Dr. Carter, you are live. Please, if you want to ask a question.
Yes, my dear. I have some comment.
Yes,
that diurnal variations are very, very important. In glaucoma suspects, until unless we do the diurnal variation, it will be difficult to label it difference between 5 or more in 24 hours. This is important to my mind. And number 2, frequent change of reading glasses. I would like to consider him for medical treatment. Thank you.
Thank you, Captain. Any comments about that? Any comment, Dr. Barol, about his comments, please?
Phasing or diurnal variation is important, but if it's much significant, if it's somewhere to the tune of 7 or 8, it can be a point which might tilt your decision towards starting treatment, but the fluctuation has not been shown to be either a predictive or a risk factor in the studies that have finally been concluded. And if somebody goes back to see the WGA consensus guidelines, fluctuations in pressures have not been accounted for as a predictive or a risk factor. So you can definitely do it. It might just support your decision making towards starting treatment. But just for somebody who is having a fluctuation in pressure, I don't think that should be the basis of starting treatment. I would ask Dr. Ronnie regarding this fact. What is his take on this?
I think it basically stems from the theory that glaucomas have fluctuations of more than 6 millimeters of mercury. Most normals would have fluctuation less than that in a day. So somebody who's fluctuating more than that, you are assuming that they have a greater tendency to be POG than otherwise. But I agree with you. There's really no evidence in ocular hypertensives and this suspects that increased fluctuation increases the risk of progression. In established disease, yes, but not in these cases. So I would take the big picture and not really keep it as only this. But if he's fluctuating like by something like 12 to 15 millimeters of mercury, then definitely we would go ahead and treat.
Agreed.
The value add for doing a phasing is only in the fact that you tend to pick up peak IOPs, which you may not otherwise see in the clinic unless you get the patient coming in at multiple time points during his or her regular clinic visits. So you might find a patient who's on medications is always 18, but he's still progressing, and you realize that if you do a phasing, he might actually pick up the 23 or the 24 that he may have at another point in time. He's not been visiting the clinic because he visits the clinic always at one particular point in time during the day. That's the big value add. Otherwise, I agree with both what Ronnie and Parul were saying.
Maybe we can consider it's an add factor. I mean, we can add it to another factor. Yes, it's maybe, but as alone, you cannot depend on that. That's a true state. Okay, so now we can go to our next speaker, Dr. Hayat. He will talk about challenging in congenital glaucoma. Dr. Hayat, please. Unmute yourself, Dr. Hayat, first.
Hello, everybody. Assalamu alaikum. I hope people can hear me.
Yeah, your voice is very clear, Dr. Hayat. Go ahead, please.
Thank you so much. Thank you so much. So,
share your
of course, this has been more of a discussion, more adult. So I'm going to just switch gears, and we're going to have a very interesting case to discuss today with our colleagues. So I'm going to just now share my screen. Let me see. Here we go. So sharing. Yes. Can people see the screen?
Yeah, please. Go ahead, please.
Okay. So congenital glaucoma challenges. Definitely, when we look at congenital glaucoma, we can actually sometimes expect the unexpected and can end up in big troubles and can be really sometimes problematic. And it all starts from the very beginning. Let's say when a child comes to our clinic and we start our examination, and sometimes the baby is crying and we really don't know what to do. There's lack of cooperation. We know that to examine, we need to have a complete different standpoint on how the anatomical structures are. And based on that, we may require to sometimes either to sedate or take the baby for an examination under general anesthesia. And of course, before and after surgery, and sometimes kids, they are having fist fight with their brothers, sisters, and, protecting the eye is another big challenge. Applying medication, monitoring complication, of course, they're all big challenges. And of course, that the kids, the palpebral fissure is smaller and the eye is so less rigid, and the whole sclera is tends to thin out, and we need to actually sometimes have different problems, like we have problems in differentiating even the landmarks, especially in an eye which is ophthalmic. So I'll just quickly go in. Glaucoma classification, if you see, it can be actually a primary and isolated idiopathic development abnormality, or it can be actually an outflow reduction due to congenital ocular or systemic disorder, or it can be an acquired one. And just to throw a question here, I would like to throw this. You see this baby, and as this baby walks in, of course, a lot of different things come to our mind. It can be a case of mucopolysaccharidosis, where the pressure can be normal, this child may not be cooperating, or it can be ophthalmos. It can be even any of these above. So we're going to find out in this talk how we can actually look in, and as I'm just trying to say here is this is a bilateral corneal clouding and a craniofacial characteristic of Hurler syndrome, and the IOP is absolutely normal. So whenever we are expecting something, well, life can be full of unexpected surprises. So we need to know, especially looking in the pediatric population in mind, the distentability of the globe at birth for the first few years of life, which causes the cornea to increase in diameter. The interior chamber, the structures, they shift, the sclera, the global enlargement, the axial myopia, and the thinning of the sclera causing staphylomas. And when we look at the optic nerve, they can actually have cupping, which can also be funny, as the only condition where you can actually see a reversal of cupping. And why is it? Because, of course, the scleral canal, it is elastic at that age, and it can enlarge its diameter due to pressure and come back and causing a decrease in cupping. And of course, there may be a posterior displacement of the lamina cribrosa. So let's go on to a very interesting case, which was referred to by my colleagues, esteemed colleagues, and well, this kid looked quite dysmorphic, if you see, and he came at 41 days age, and he had 2 or 3 brothers and sisters which were normal, but this kid had an antenatal diagnosis of short bilateral upper and lower limbs. And he was born, his mother, 33-year-old woman. There's no family history of dwarfism, cardiac or skeletal abnormalities. And we look into it was referred with Pierre Robin sequence, micrognathia, depressed nasal bridge, skeletal dysplasia with short limbs, bilateral talipes equinovarus, pulmonary hypoplasia, a whole bunch. I mean, if you look at there were a whole bunch of things, and that's the reason when they looked at, there was glaucomatous optic atrophy seen. The patient was referred to me, and patient also had a reducible inguinal hernia. So this was like a kind of a disease which was more systemic rather than just having an ophthalmic cause. And the eye looked, of course, proptotic, ophthalmic, and even when we looked at the CT, which few pictures came through WhatsApp, it looked like very shallow orbits, and we don't know whether it is the eyeball which is huge or whether what's happening. And of course, there was a lot of cupping, about 8.8 to 0.85 cupping in both eyes. And in the left eye, peripherally, through the hazy cornea, we could actually see a superior temporal chorioretinal lacunae which was present. So there were some defects there. So we were suspecting something which can actually be causing not only the eye but the whole body. When we looked in, a collagenopathy may be associated with the very early infantile glaucoma, which was actually not many cases. So we tried to look in, and what we found is that basically goniotrabecular dysgenesis, they can be actually, mostly they are isolated, and then usually they are primary glaucoma, which we see, but sometimes there were reports that they can be associated with Stickler Syndrome and osteogenesis imperfecta and other collagen disorders. So this was a challenging case, and of course, when we plan a surgery for a case like that, of course, we have to plan for something real good, because the baby has whole life ahead, and it should be performed by somebody who does this quite often, not by an occasional, just untrained surgeon, and of course, considerable volume and experience, where we actually struggle in UAE. We don't get the kind of numbers my colleagues from India get. And of course, anesthesia safety is another view which we had to look in. And when we looked at what may be the possible surgeries, of course, the angle surgeries are the mainstay where, of course, if the cornea was a relatively clearer, which was not the case here, we could have gone for a goniotomy, or the case like here where there was cornea was a more cloudy, a trabeculectomy can be done. Of course, another option is to go for a deep sclerectomy, or looking at the whole systemic condition and severity, a possibility of combining trabeculectomy with trabeculotomy and the use of mitomycin C as a primary procedure could have been thought. And then, of course, a glaucoma drainage device can also be an option in children, of course, but this is an option when the primary mainstay surgeries of goniotomy and trabeculotomy fail. So we actually thought of waiting and going for an examination under general anesthesia, and then we would make a judgment as what we have to do. So what we found was the pressure was pretty high. They were in 40s, and the corneal diameters were over 14 millimeter. And of course, the left eye was more severely affected than the right eye. There were presence of hapstri. The anterior chamber was deep, and the iris looked thinned out, and we could hardly see any pupillary reaction. The lens looked clear, and it was looking as if it is bulging into the anterior chamber, and we could see the optic disc with cupping. And when we looked at the B scan, we found out it showed normal vitreous cavity and attached retina with an axial length of almost 28 millimeter to 29 millimeter in each of the eyes. And that actually explained that it looked like a very crowded orbit, and that is because of a big axial length that you see here. So what we planned was, we actually planned for a combined trabeculotomy with trabeculectomy and the use of mitomycin C 0.2% as the primary procedure. As you can see, the cornea was hazy, and then of course limbal base flap was made. I'm gonna just so conjunctiva very carefully dissected out and of course cauterized to ensure that we get a good triangular flap, scleral flap done. And always, sometimes I even go for a rectangular flap. I think the other eye did a rectangular flap. And I sometimes even use the releasable sutures. That is sometimes helpful because we don't get the children to get a laser to do a suture lysis. So sometimes it's helpful in bringing down the pressure if it is going up using the 4th row. But in this case, as you see, once we went in and we see the demarcation line, then we marked out the area where we want to do the trabeculectomy, and then we straight away went for the trabeculotomy. And the important is the gray area, and a very slow dissection has to be done to ensure the moment we see some oozing out, that's the time we know. Sometimes I even use the 5-0 nylon to just ensure that I have the skin out. And then using the Harms trabecular comb, we did the trabeculotomy, which was followed by a trabeculectomy. Sometimes I use Kelly sponge also. And of course, a peripheral iridectomy was performed successfully in both the eyes. And of course, the wound was closed. So sometimes it's very difficult to know the structures. Sometimes they may not be in the position where you're expecting. and it becomes challenging, it may not be so easy. And in those cases, I think now the eye stent is very good, and it helps us to eliminate that area. And sometimes I use the elimination just to endo illuminator just to see the structures, to see where exactly they are. So post surgery, bleb was very well formed and there was no leakage. Post op, 1 week, there was a lot of chemosis, and we had put a very frequent steroid and antibiotic combination. I was alternative day dilating the pupil using tropicamide and phenylephrine eye drops, just to make sure that the pupil is not stuck in a one position. Also, there was hyphema, which was more on the left side as compared to the right eye. And slowly the hyphema actually resolved. And because the baby was lying in a supine position, the hyphema was actually on the iris. It was not in the anterior chamber, it was just sticking off blood. And then after a while, we found that it was improving, and the blebs were quite well. And 1 month, of course, it's quite stable. The corneas have cleared, the cupping has also improved. Now, we found out that the genetics workup came back, and full gene sequencing was done. And we found that the patient actually had an autosomal dominant spondyloepiphyseal dysplasia congenita, which is actually the going out with the systemic situation of the baby. And of course, Stickler Syndrome 1. This was actually a novel mutation that we found. And this was very interesting because not many cases have been published. And the last report, which actually talks about the association of infantile glaucoma with collagen disorders, the association of Stickler syndrome and osteogenesis imperfecta. And they actually looked in, and they found not many cases having this condition. So when we looked at the Stickler syndrome, the mutations actually can be either the collagen type A, type 1 alpha 1, or that is the type 1, or it can be the type 11 alpha 1. Based on that, we call them type 1 or 2. And then, of course, there may be accordingly the abnormalities in the collagen fibrils. And the type 1 actually usually affects the vitreous humor, sclera, cornea, trabecular meshwork. And I think that is the reason this child was so severely affected and had glaucoma at birth. While if you see the type 11 and the type 2 or the type 11 collagen fibrils, they basically usually found in cartilages and may also be found in vitreous. So Stickler syndrome, this was an interesting case I had seen first time, where of course there was pair of sequenced and hearing loss, hypermobility joints, and they actually reported that this is the most common abnormality in non-glaucomatous is the axial lengthening with high myopia, and these are quite predisposed to retina detachment. Thanks God, the last time we did the B scan, everything, fingers crossed, was very good. We didn't have anything, but usually they find this happens later on in life. They also have predisposition of ocular hypertension and angular abnormalities, and they usually also go later. But there are only 2 cases like this reported where there is an infantile onset of glaucoma with Stickler syndrome in the literature. So looking at the surgery, actually, if we see, let's talk about comparing the goniotomy with the trabeculotomy. Of course, the pros and cons when we look at goniotomy is definitely a simpler, faster procedure, doesn't take more than 5 to 10 minutes, but definitely you need an operating microscope where you can actually incline it. At the same time, you basically ensure that you do not, you need to have the patient head also tilted, and the cornea, most importantly, has to be clear. And a direct visualization of the trabecular meshwork is necessary. And of course, you may actually repeat at a time if you have done 120 degrees. The most common and easy area that we can actually go in is the inferior nasal, because we will go superior temporally, and that's the easiest quadrant to go. But of course, once the corneas are not so clear and they are cloudy, of course, then we need to have a more elaborate and lengthier procedure, which of course disturbs the conjunctiva, that is trabeculotomy. And of course, success rate, people say they are comparative, but well, actually they're designed for completely different indications. So I don't really believe that that's fair to compare them to have almost equal effectivity, because they are for two different conditions and how the glaucoma is presenting. So if we summarize, actually looking at the recent advances, of course, there's a lot of use of implants, the drainage devices like Hamilton implantants, is quite a few of us doing nowadays. And especially when we do it actually in children, my whole reason is that to take the child again and again, if the pressure is low, is extremely difficult. You need to put the baby under general anesthesia. So my preference has been Ahmed valve, but of course the long-term results have not been so promising in Ahmed valve as compared to the ones which have larger plates. And I tend to, even for Ahmed valve, I tend to use adult plates, because I feel the pediatric plates are really small. The new techniques, of course, visualize cannulation and opening of the Scrims canal. There is now use of Omni system, where actually the gonioscopy assisted
Dr.
trans.
Hayat,
Yeah.
can you
Yeah.
please conclude, because we are
Yeah.
now
Sure.
5 minutes,
Sure.
please.
Yeah, I'm actually not seeing the
You
time
are
actually.
speaking very slowly, that's why you didn't notice
Okay.
the time, I think.
Okay. So basically, we can
Only one word,
actually,
please,
yeah, we can actually also go for 360-degree trabeculotomy, which is also a good way. We can go for deep sclerectomy, and of course we can go for the cyclodestructive procedures. We can take the transscleral diode laser cyclophotocoagulation, or a much safer way is, especially in cases where the patients are aphakic, an endolaser cyclophotoablation can also be done. So in the end, of course, that was my last slide. Actually, we need to be prepared, and we have to have a high degree of caution, and we can sometimes expect the unexpected. And of course, life is full of surprises.
Thank you, Dr.
Thank you.
Thank you very much. Thank you, Dr. Hayat, for a great procedure. We can go now directly to Dr. James. Dr. James, he will give a talk about strange things are afoot in the glaucoma clinic. Yeah, I know we are late, but we can go fast as possible as we can. Dr. Hayat, next time I will kill him. No problem, not this time.
Thank you very much. Thank you for inviting me this evening. Thank you for the excellent talks thus far. It's my honor to be part of this illustrious group. I think you hopefully can see my screen. Hopefully you can now see my presentation. Good. Thank you very much.
Go ahead, yes.
Excellent. So I'm going to carry on from some of the previous talks talking about diagnosing glaucoma and just how we go about treating and approaching our patients it's always useful to think about a definition of glaucoma. Just briefly, it's a progressive optic neuropathy. And the key thing is it's got characteristic changes in the optic nerve head with corresponding loss of visual field. It's important to note that there is no mention of intraocular pressure in the actual definition of glaucoma. So really you need to diagnose it. As Dr. Ronnie says, it's a clinical diagnosis. So we're fortunate we still have a clinical diagnosis to make through examining the patient's anterior segment, gonioscopy, and then going on to the optic nerve head. So first of all, it's all useful to think about what is not glaucoma. So this is not glaucoma. I think all of us see many patients who have had slightly enlarged cup-to ratios, who've been started on medication elsewhere, and then you've got to undo that diagnosis. So in this patient, you can see nice, healthy nerve fiber layer, nice pink neuroretinal rims, symmetrical cupping, and if you look at the surrounding retina around the optic nerve head, it's nice and reflective. This is very healthy optic nerves. Again, this is a different patient. So this patient's got large cup-to ratio, but happily both nerves are very symmetrical. The actual neuroretinal rim itself is thick and healthy. The tissue is pink, and it's probably a highly myopic patient typically for these patients. You can see the left optic nerve head, the cup is so deep that the fundus camera is focused on the retina itself, and the lamina cribrosa, at the base of the cup is not in focus. So when you have such large discs, you've got to bear that in mind with the photography. But this patient's eyes are healthy. You can be reassured with these patients. So an important thing to think about with glaucoma is asymmetry. So particularly with patients with low risk glaucoma, open angle glaucoma, asymmetry between the right and the left eye, and asymmetry between the superior and inferior visual fields helps us diagnose the condition. So this is typical glaucomatous disc asymmetry. You can see the optic nerve head of the right eye, which is the left of the image, is grossly excavated. You can see bayoneting of the blood vessels. The nerve fiber layer of the retina has lost its reflectivity, and this is a very large cup-to ratio. Whereas on the left, the nerve is healthy in comparison, and this asymmetry helps us guide the diagnosis. So first, we're going to look at a patient as a case study, and then hopefully illustrate some of the points I'm making. So this is a patient with very, very early glaucomatous damage, a 58-year-old male hyperope, intraocular pressures of 30 and in the right and 18 in the left, a presentation using Azaga once daily, and on gonoscopy had narrow angles. So patients using Azaga once a day, now we know that this medication, the combination of timolol and brinzolamide, it should be used twice daily. So it's important always to check compliance with patients. And if they say they're using the drops, how many times a day do they actually use them? And when did they last use them? So compliance is a very important element of glaucoma care, which we mustn't forget, as is gonioscopy. Often gonioscopy is overlooked and ignored, but it's key really to diagnose patients. We know open angle glaucoma is more common, but angle closure glaucoma often will be more severe and can progress more rapidly at certain times within the disease process. This patient had laser peripheral iridotomies performed elsewhere, but despite using the Azaga twice a day as correctly instructed, the IOP control was still poor. So I switched the patient to a different combination therapy of Ganfort, and intraocular pressures reduced nicely to 12 and 14. So by switching medication to a different combination therapy, I could have in this situation reasonably just used Lumigan, but I felt it was better to just go ahead and hit it with combination therapy. So this is the patient himself. So you can see again the right eye with high intraocular pressure is slightly excavated on the color image. This is an Optos image. It's not as clear as the previous Zeiss image. So the disc is slightly enlarged. You can see very subtle changes on the OCT in the center of the screen. The right eye has got a slightly reduced nerve fiber layer. And again, correspondingly, the right visual field has got a very early nasal step in the right eye. So the visual field on the right of the screen is for the right eye, and on the left of the screen is for the left eye. So on the left eye visual field, that's a non-specific peripheral non-glaucomatous visual field defect, so that is not significant. Whereas on the right eye, you can see that very early nasal step, which is inferior, and that corresponds with a slight thinning of the superior rim of the retinal nerve fiber layer. So this is just a patient with very early glaucoma. In contrast, the next patient that I saw, or for this presentation, a 51-year-old healthy male, 20/20 vision, so very good visual acuity and open angles. So when I saw him in clinic, despite triple therapy, intraocular pressure was still high in the left eye, which is the severely affected eye at 24. So you can see here on the OCT, the left nerve fiber layer is obliterated, and correspondingly, the left visual field is grossly reduced. And this is, quite clearly severe glaucoma. And so rather than keeping the patient in clinic for months and months, even on the second visit, I listed the patient for a trabeculectomy with mitomycin C. Pressure was 24, which is not high in and of itself, but in this patient, a pressure of 24 in a 51-year-old healthy male with good visual acuity is really too high, and so they need aggressive therapy. So this is really important. This was mentioned before, risk stratification. So you've got to individualize patient care based on the amount of glaucoma damage, life expectancy of the patient, the untreated IOP before medication, so the baseline IOP before treatment, and other factors such as rate of progression. So depending on these factors, allows you to either have a higher target IOP or a lower target IOP. So particularly with the patient I just mentioned there, we need a very low pressure to preserve his visual field for the rest of his life. So just changing tack slightly. So first of all, I've spoken about disease severity. Now I'm going to talk about other conditions which can appear in the glaucoma clinic. So this was a patient referred with the question, has the patient got normal tension glaucoma? So they're querying the right eye because the physician thought the right nerve, the right cuppus ratio was greater than the left, so I was worried about glaucoma. But as was mentioned before with OCTs, you have to interpret them with a pinch of salt, and actually the right optic disc is larger than the left optic disc. So if you measure the height of the nerve vertically or horizontally even, with your 78D lens or whatever lens you use in clinic with a dilated pupil, it's always important to dilate these patients' pupils, have a good look at the optic disc. You'll see the right optic nerve is larger than the left. And if you look at the left OCT in front of you, you can see, if you look at the middle image, you can see the nerve fiber layer is bunched inwardly. So it's sort of bunched across. So the lines on the nerve fiber layer scan are out of sync with the normative database. So the red and green images just compare the patient to a normative database, and the machine is confused by this patient because the left optic nerve is smaller than normal. And so the OCT is incorrectly saying the patient's got glaucoma, because actually this patient, is fine, and you can reassure them they've just got physiological disc asymmetry. This is a different patient, also referred to clinic. Does this patient have normal tension glaucoma? So this is a 52-year-old female patient with prior LASIK for myopia. Patient had recently had bilateral cataract surgery, and after surgery, patient has subjectively poor vision. So they had the cataract surgery, previous LASIK, good post-operative refractive result, which you can see here on the right. If I'd done a phaco post-operative, I'd be happy with that. -1 in the previous LASIK patient is great. The patient subjectively still not happy. Just looking grossly at this macular OCT, you can see, it's very bluey and greeny, which is certainly with the Heidelberg OCT is indicative of thinning of the whole nerve fiber layer. And it's not in and of itself enough, but certainly that would make us cautious and perhaps slightly concerned or worried. And indeed, when we look at this patient's OCT of the optic nerve head itself, you can see, again, completely flat profile of the OCT of the optic nerve, all red because it's out of the normative range of data. And indeed, both optic nerves look quite pale. So this is the Optos scan from before the cataract surgery. So even at this stage, you can see the discs are quite pale, although it can be hard to see through, through the patient's cataracts. But certainly this patient did have pale discs with corresponding damage on the OCT, as well as reduced visual fields bilaterally. So the patient has bilateral optic atrophy. Of note, the patient previously had treatment for TB medically, as well as chemotherapy for colon carcinoma. So in this sort of patient, it could be a toxic optic neuropathy causing this condition, although further investigation is required, including usually neuroimaging. Usually these patients will have MRI of the brain. So one last patient just to talk about. This is a patient with unilateral blurred vision who came to clinic. Young patient, 40-year-old male, previously worked in the army. 6 months gradual reduction in vision in his right eye. Patient says it's worse at night, he notices when it's driving. And on exam, he's got a right posterior subcapsular cataract. So, you probably think this is an open and shut case. Let's just get on and do the phaco. What's concerning, or what's of note on the findings, are that the visual acuity in the right eye, the affected eye, does not improve with pinhole. So whenever a patient's VA does not improve with pinhole, particularly in a young patient with a mild cataract, you've got to be suspicious that maybe there's something else going on. And indeed, lo and behold, you can see again, optic atrophy is the culprit. So they've got a pale right optic disc compared to the nice healthy left optic disc. So this is not glaucomatous, this is most likely traumatic. So, particularly his history of working in the army is relevant. Often patients like this can have trauma, which either they forget about or they don't want to admit to. So posterior subcapsular cataract combined with pale optic disc is likely to be due to trauma, although again, neuroimaging would be important to rule out any other causes of this along with other tests. But again, always be cautious in patients like this when things don't quite add up. So always check the pinhole visual acuity. So in summary, performing or making careful diagnosis is crucial for patient management. We must individualize patient management and patient care by risk stratification based on coexisting risk factors such as secondary glaucoma, angle closure glaucoma, neovascular glaucoma, etc. And always assess patients carefully for alternative diagnoses or coexisting pathology. So careful clinical examination. So we enjoy our ophthalmology, we enjoy clinical examination. So make sure you do it carefully at the outset to avoid any issues further down the line. Thank you very much for your attention this evening.
Thank you, James, for this nice presentation. Without further delay, we can go directly to last speaker, Dr. Rajesh. Then maybe we can have a question about the last 3 presentations. Rajesh will talk about fast-forward glaucoma management in the future. Dr. Rajesh, please.
Thank you very much. I hope you can all hear me.
Yeah, your voice is very clear. We can hear.
Okay. So, okay. Unfortunately, glaucoma, as we've all seen over the last few presentations, it's kind of clear that there's no clear answer to the management of this disease because glaucoma is primarily multifactorial. There is no single treatment modality that works right. There's no clear answer to the cause and effect. We know that intraocular pressure is a risk factor, but it's only a risk factor. It is not the only cause, and there are other reasons. And the need of the hour, of course, is tailor-made therapy, which we don't have at this point in time, except for treating intraocular pressure. So many times I do tell that we might be barking up the wrong tree. However, that's the only tree we know what to bark up at, the intraocular pressure. And further, all this is compounded by the patient's general difficulty in access to good health care, being able to see the right specialists. There's paucity of resources. The number of glaucoma-trained ophthalmologists are not that many around even now. And that sort of adds to the whole compendium of management issues that we see. Now, and as Dr. Amri has mentioned earlier, you're looking at about 80 million sufferers in the year 2020, and this is supposed to project out to about close to 112 million by the year 2040. Now, where do we go from here in terms of management? I mean, there are drops that we use. There are surgical approaches. There is this neuroprotection as a treatment modality, and then of course there could be gene therapy. Now, I will not discuss surgical approaches because I think um, all the esteemed you know speakers and the audience would have had ad nauseum sort of talks heard on the new MIGS and other procedures. So I will stay away from that and talk about something a little different in terms of medical management. Now, there have been a lot of talks about systemic approaches to managing glaucoma. So to start with, there have been medications that have been looked at: anti-glycemic medications, statins, serotonin reuptake inhibitors, some of the antidepressants, cannabinoids, interestingly, postmenopausal hormones, and calcium channel blockers. Now, metformin has been shown to, in some retrospective studies, in fact, large studies, show about a 24% reduction in open angle glaucoma. And this could be because there is improved vascularity because of glycemic control. And also there could be an anti-inflammatory or a neurogenesis angle to it. Interestingly, there have been a lot of sort of focus on statins and in large population-based studies from the point of angle is there a neuroprotective effect of statins in patients who have open angle glaucoma? So what happens with statins is primarily causes an upregulation of the endothelial nitric oxide synthetase pathways, and this may then cause vasodilatation and allow increased retinal and choroidal perfusion, and hence probably prevent cell apoptosis and cell death. Further, this can also has been shown to sort of increase the outflow activity through the trabecular meshwork and reduce intraocular pressure, and also decrease the glutamate-mediated retinal toxicity pathways. If you look at, about 0.3% of reduction in progression has been seen in those who were on statins for every additional month of use. And it's been shown that if someone took statins for almost 2 years, there was a 5% reduction in the risk of POAG progression. Now, there was no dose-dependent difference. However, some studies have shown that quite the opposite, that there has been an increase in intraocular pressure or progression of open angle glaucoma. Now, the argument is that many of these patients have so many comorbidities that it's confounding all the variables, and hence there is no proper prospective studies to actually find the actual cause and effect. So beta blockers could be a concomitant effect in these patients because they have all these comorbidities, and that could be the reason why there is so much of confusion in the results. Now, if you look at the SSRIs and the other antidepressants like bupropion, basically these have been shown to these patients who are on these medications have been shown to have a 30% reduction in open angle glaucoma who require further treatment. Now, the pathology, or rather the pathophysiology behind this is that these patients, there are receptors in the retinal ganglion cells, and there is some evidence that these may modulate the intraocular pressure. However, there have been an equal number of studies as in the other, drugs that have shown no cause and effect sometimes. Now, if you look at the estrogen-based receptors that are present in the RGCs, estrogens have been found to decrease intraocular pressure and provide a sort of a protective effect in patients who are on postmenopausal hormones. Now, coming to the interesting cannabinoids, although there has been a legalization of cannabinoids across many countries and in the US as well recently, there have been recommendations from the American Academy of Ophthalmology, very specifically saying that although there have been cannabinoid 1 receptors found in the ciliary epithelium and in the trabecular meshwork and the Schlemm's canal, there is no substantial evidence to show a protective effect, because you need substantial and frequent doses of cannabinoids, which may actually cause other side effects that we all know of, rather than being protective or useful for the treatment of intraocular pressure control. Now, calcium channel blockers have been studied multiple times. It has been shown that it can increase optic nerve head and choroidal blood flow. However, there are limitations because calcium channel blockers are never the first line therapy for hypertension and always like second line therapy. Now, in terms of what are the newer medications available, two of them that have been recently released or in the process of being launched in every other part of the world is, one is the latanoprostene Bunod, which is basically combining the effect of a prostaglandin analog in reducing intraocular pressure by improving the uvascular outflow, and also having a nitric oxide donating prostaglandin, where the nitric oxide actually releases the trabecular meshwork and Schlem's canal and improves the trabecular outflow pathways. Further, the new Rho kinase inhibitor, which is the netarsudyl, has been shown to sort of manipulate the cytoexoskeleton of the eye's outflow pathways that can increase the outflow and thereby sort of the 3 rocket studies that have been published have actually compared netarsudyl with timolol, and there's only one study that actually looked at comparing it with latanoprost. Now, with latanoprost, though, in the 224 patients, they did not find a non-inferiority, or rather the non-inferiority was not really proven, but found that they were kind of equally effective, but not inferior or superior to the medication. I just wanted to touch upon also 24-hour Iop monitoring, which can become sort of kind of relevant in our moving forward. Now, what's the relevance? One, we're looking at intraocular pressure as a modifiable risk factor. There's the focus of treatment is intraocular pressure, and Iop measurement is usually with the Goldman ablation tonometry. Now, what are the measurement limitations usually? The single most limiting factor is the fact that most times we do a single measurement at a single point in time, and this is the biases are from the pachymetry, from the biomechanics that we do not consider, from the fact that the scleral rigidity can itself influence the readings, and this is actually an indirect measurement. We do not have anything that is stuck into the eye that is actually measuring it, which would be the ideal measure. So it is a dynamic event. If you look at the dynamic contour tonometry, that actually shows the dynamic event. There are postural variations that can happen. There is a circadian rhythm that we know about. And we always do not identify, as I mentioned earlier in the discussion, the peak IOP. Is there a role in the diurnal variation of pressure? Do we actually look at nocturnal or sleep IOP, which is, again, logistically kind of impossible in most settings, even for the patient as well as for the physician? And what is the role of fluctuation? I know there have been different schools of thought and arguments about this, but self-monitoring has its limitations. So moving forward, is an implantable intraocular pressure sensor the way to go? What are the risks of doing this? Is there what are the toxicity problems? Can there be a device failure? Yes. So putting an implantable sensor into an intraocular lens might be the way forward. However, we do not know what the accuracy would be, and it also, of course, involves surgery. Now, disposable soft contact lenses like the Sensimed that I worked with have actually sort of moved forward in trying to allow us to measure pressure 24 hours. Having said that, it's still kind of in its stage of infancy. Although it's just a simple contact lens which has got multiple base curves and got a highly sensitive strain gauge, the values it gives are actually in terms of peaks and troughs and are not actually representative of the intraocular pressure. And they're actually electrical impulses which need to be then converted into values that could match the intraocular pressure. So the advantage is that it records intraocular pressure through the day for 24 hours, and it takes into account the effects of blink or eye movements. But like I mentioned, the output is not in millimeters of mercury, and then you need to correlate these readings with that of the findings, which can be sometimes challenging. So the other problem with this would be there would be a lot of data, big data output from this, and then you would have to sort of have special software to analyze this data and figure out how to interpret this data and how with each phase, like the acrophase or the bathyphase, actually there is the peak or the trough, how do you actually then apply it clinically to the patient? And this would be a challenge. Now, there's also been the Argos, which was released some time back. Or, however, I don't think it has gone beyond its research phase, it was an implantable lens with a sensor. However, there have been no further discussions about this in the future. Now, translation to treatment modifications, the question is, if we do find significance of 24-hour IOP, do we have medications that can help fix this problem? What's the effect of nocturnal and intraocular pressure on the development or progression of the disease? And of course, cost effectiveness becomes a major factor here. Gene therapy, this would be the final frontier for glaucoma. Now, the biggest problem with glaucoma is that whatever damage happens is irreversible. And so there have been a lot of talk about gene therapy. Now, there have been a lot of papers that were published about gene discovery. So we have discovered a lot of genes that allows for novel therapies. And this would allow then to target what the actual molecular events responsible for the disease would be. And advances in methods for gene replacement with the CRISPR-Cas gene editing actually sort of opens up doors to sort of then utilize the data from the gene discovery, like the Loxel genes and the CYP1B1 genes, to sort of then move forward and say, okay, how do we then use this information that we got from all these gene discovery data to actually do something in terms of preventing or arresting development? Now, removing myocilin, for example, which is a well-known genetic mutation by gene editing, has been shown to lower the intraocular pressure in mice, which carries the MYOC mutation. Similarly, it has been also found that mitochondrial function can be targeted. Now, this reductase enzyme, which codes for the proteins required for reducing oxidative stress and maintaining redox homeostasis. And these enzyme variations have been seen in both strongly associated with both intraocular pressure and POAG. We need an integrative approach in the sense that we need to match or marry proteomics, genetics, and pre-immune and immune events to glaucoma, because this whole thing is a compendium. There have been a lot of papers that published about how inflammation and the immune system is involved, how oxidative stress can cause glaucoma, how vascular events can cause glaucoma, and of course the genetic events that we've spoken about. Now, in a nutshell, yes, glaucoma affects retinal ganglion cells, and the current focus of therapy is in controlling the intraocular pressure, and this involves the trabecular meshwork. Now, if it's oxidative stress that affects the trabecular meshwork, that means that the trabecular meshwork motility and cytoarchitecture can get affected, and this is causing apoptosis and loss of the blood aqueous barrier, right? Now, if you look at this, then intraocular pressure rise can be affected by the TM expression proteins that are altered the aqueous humor, and thus functional proteomics may play a role in sort of determining how these trabecular meshwork function changes happen. Now, where are we going with this information? Aquaporins have been recently sort of come into the fore in the management of eye diseases. And although it's been around for a while, this was a Nobel Prize winning sort of discovery. It's a naturally occurring water channel in the body in which there are 13 of them, of which there are some that are present in the eye. And it's been found that aquaporin expression is at the level of the epithelium, endothelium, and other cell structures. From this image, you can actually see that there's aquaporin 5 in the lacrimal gland, and 1 in the corneal epithelium and trabecular meshwork. And there has been shown that deletion of certain aquaporins can cause reduced aqueous production and also some effect on the outflow. So this was a very recent paper that got published that actually showed that um, the gene aquaporin 1 disruption can actually improve outflow, and this is a potential pathway to genetic mutation, to sort of find the effect of genetic mutations or genetic disease subtype, and then look at how we can look at additional methods which are not sort of pharmacological modulations but genetic modulations. I want to conclude with this, that there is so much of subjectivity between inter-visit and intra-visit and inter-specialist visits with diagnosis sometimes. Even if you take me or Dr. Amri or Dr. Ronnie, sometimes the same patient, we may come up with different cup disc ratios, different angle analysis, and this is dependent on the time of the day. If I see a patient at 8 o'clock versus seeing a patient at 5 o'clock, my diagnosis can be different sometimes depending on how tired we are. Although this is not acceptable, we are all human and we are all burdened with the fact that we have a lot of patients to take care of. So there is also this paucity of resources, like I mentioned earlier, in terms of clinician time and as well as paucity of resources. And moving forward, I think we have to look at ways how we provide glaucoma management to the doorstep of the patient rather than expecting the patient to come to us, because that is when we reach across and reduce the gap in patient healthcare and access. Now, what happens if we do telemedicine or teleglaucoma is that we will end up having lots of data, which will not be then sort of if you look at it, allow for subjectivity here and developing models that can actually do the diagnosis and decision making for us, and then leading us to look at pure clinical management of these patients would be the way forward. The objectives of treatment for glaucoma, we should always remember, should be to prevent the disease if possible. If the disease is there, to prevent progression. If the disease is progression, to try and prevent disability to the time that the patient is alive. And most of all, prevent blindness. Thank you.
Thank you, Rajesh, for this all information. You collect so many things about the future. Really, most of us, we are not aware of these all things that running, because it's not usually applicable, or we are not using this method until now. But we hope in the future it will be more clear and more prominent that we can use all this technology or this future management that you share with us about the future. Thanks a lot, and thanks for James, thanks for Dr. Hayat. There is one raised hand, Dr. Batisho. He will ask a question. Dr. Batisho, if you are, can you unmute Dr. Batisho, please?
We're awaiting for him.
Yeah, just unmute him if you can unmute. Dr. Batisho, if you are listening to us, please unmute yourself, and you are now live. If there is any comment before Dr. Batisho from or question to Dr. Rajesh or Dr. James or Dr. Hayat from any other or in between. James, you don't want to ask your friend Dr. Rajesh about what he mentioned, especially the gene therapy?
Yeah, it's very interesting. It's a potential source of treatments in the future. Essentially, glaucoma is currently untreatable. We just reduce progression. So if there can be treatments in the future, that can be very exciting. Watch this space.
I like the things that about medication you are mentioned, Dr. Rajesh, especially the metformins and these things. Is this, if there is a study about that one and show there is, treatment, or you are a patient having, they found it accidentally, he is a diabetic, then he is at the same time glaucoma, and that decrease the pressure on his, when he is taking metformin?
I think most of the study results are kind of piggyback post hoc data that was collected when large-scale studies were done. There, like I said, there are conflicting reports from large studies, and it goes both ways. There's one whole bunch of papers that show that it's protective, another bunch of papers that show no use at all whatsoever, another bunch that shows no association. So I don't think there is enough information out there to sort of isolate a single systemic medication for future therapy at this point in time.
Thank you. I don't know, Dr. Batisha, maybe he is not showing. Anyway, I would like first of all to thank you all. Special thanks to Dr. Ronnie and Dr. Barrel, because we keep them till this last, they are this now almost midnight with them. We are sorry for that, but we cannot change the time in UAE. We hope the future we can do something. Maybe James, you can take care about this one, or Rajesh. They are the responsibility they have taken. Thanks a lot. It was great to meet you. Great to meet you, Dr. Barrel, and to see you after this 1 year now. We didn't see you. Thanks for Dr. Rajesh for all information, and also special thanks for my dear friend Dr. Hayat. He showed us a congenital glaucoma, something different what we are talking about. Very special thanks also to my dear friend James, and thanks also to Mundi Pharma for supporting this meeting. And I'd like also to thank all the participants they are with us. And we hope to see you soon, inshallah. Thank you and good night.
Thank you, everyone.
Thank you.
Great
Thank
to see
you. Nice to meet you all. Thank you very much.
Nice
Bye.
Thank you very much.
Thank you.
Thank you.
Thanks, Hayat. Okay, thank you, John. See you, inshallah.
Most welcome.